Right ahead.
All right, so today we're going to talk about diabetic ketoacidosis, kind of fitting timing right now because this month, November, is Diabetes Awareness Month. And I felt like this meme last night while I was doing the PowerPoint as, A, the world's crazy, and then my life is crazy because I have a huge gas leak at home and a refrigerator don't fit where it's supposed to, and I was working on DKA instead. So our objectives for the lecture today, we're going to work on defining diabetic ketoacidosis, understanding the pathophysiology and how that plays into DKA and our treatment strategies, reviewing those treatment goals as well as their managements in hopes of avoiding any complications as we're managing DKA, and especially review cerebral edema, as that's the main complication we're looking to avoid. So before we start, this is Gamble's bread and butter. It's his favorite topic. So I thought I'd share a few words of wisdom from Dr. Gamble. Eat when you can, sleep when you can, don't stand when you can sit down, don't sit when you can lie down, don't fix it if it's not broken, and finally, don't F with the pancreas. So to start, we'll work on defining diabetic ketoacidosis. So what is DKA? It's pretty simple. This is one that I don't think it's worth memorizing, but the Pediatric Endocrine Society, both in Europe and America, have the same definition. So you can easily remember each component of the D, K, and A. For diabetic, we want to see hyperglycemia. Usually this is defined as a glucose of greater than 200 milligrams per deciliter. Sometimes this can be greater than 300 depending on the source that you're using. You'll also have to have ketonemia. Often you'll have keturia. So someone who has diabetes can have acidosis and not be in DKA, but if they don't have any ketones. So important to make sure you're defining that. And finally, acidosis. And this is confirmed with either a venous pH of less than 7.3 or a serum bicarb of less than 15. We further can divide our DKA into mild, moderate, and severe. So those in mild DKA will usually have a pH of about 7.2 to 7.3. Bicarb tends to be 10 to 15. In moderate, we'll see pHs of 7.1 to 7.2 with bicarbs of 5 to 10. And in severe, they'll present with pHs less than 7.1 and bicarb of less than 5. Epidemiologically wise, it tends to occur in about 1 in 300 use. This can vary depending on where you're living. The thing that we're seeing that's interesting is that our prevalence has been increasing by about 3% per year in the US. Diabetes is the most common endocrine disorder in pediatric critical care. And typically about 15 to 70% of those who have new onset diabetes will present in DKA. This will vary a little bit depending on the access to care in your community, as well as like the education level of the community and their awareness level. Obviously, those who are less educated will let symptoms go longer. If they don't have great access to care, they tend to be more likely to present in DKA as well. We're also seeing an increased frequency of type 2 diabetes presenting in DKA, anywhere from 5 to 25%. So that's also increasing our incidence of diabetic ketoacidosis in children. The most common cause of death in children with type 1 diabetes is DKA. So it's also important to recognize this and to be able to treat it appropriately. There's several risk factors to present in DKA if you have type 1 diabetes. For new onset diagnoses, the biggest risk factor is being young, so less than 5 years of age. This is because it tends to be misdiagnosed often. In these patients, they'll usually get diagnosed initially as having a URI just from their tachypnea. So important to kind of think about that. You tend not to ask as much questions about how often they're peeing and how long this has been going on, polyuria. They can't really communicate those things as well. So weight loss, also important to ask about in your history and physical on these patients. Also increasing your likelihood to present in DKA is a lack of access to healthcare, which makes sense if you're not getting seen by your doctor, or if you don't have insurance and you're trying to delay, you tend to present sicker. For recurrent DKA, again, I think we can probably think of ours popular flyer patients and come up with all these. So the most common cause of DKA is lack of insulin, and this tends to go with not administering your insulin. So those with higher hemoglobin A1C levels, prior DKA episodes tend to come back, clinical depression or psychiatric disorder, having an unstable home or situation or family dynamics. Again, your lack of access to healthcare, lower education level, especially of the parents, will also play a role. Being pre-pubertal or an adolescent female increases your risk of DKA. And then also insulin pump administration, because there's no long acting to kind of tie you over. So if something goes wrong with the pump, if you don't have a good site, if you continue to reuse the same site, or you aren't changing every 3 days, you could not get as much insulin and tend to slip into DKA a little bit easier. So what causes our DKA? How does that happen pathophysiologically? First, we have to remember what the two main hormones are doing. So insulin is kind of the go signal telling your body that there is food available. So you kind of want to take up all this and store it into your body for later use. You do this by signaling glycogen synthesis in the liver. Your peripheral tissues, including muscles, organs, etc., will also be signaled to absorb glucose. You'll also have some amino acid uptake by your muscles. Your liver will take up these amino acids as well and start to begin protein synthesis. You'll store fats as fatty acids, convert fatty acids and glycerol to triglycerides, and you'll store this in adipose tissues. Insulin also signals your body to store potassium, phosphorus, and magnesium from extracellular to intracellular spaces. And this is important later, as what we'll see, what electrolytes are often depleted in DKA. Insulin also has some inhibitory functions. It inhibits glucagon, which makes sense. You don't want your body breaking down what you're trying to build up at the same time. And it will inhibit lipolysis of triglycerides in adipose tissues. It encourages mobilization of stored fatty acids, inhibits proteolysis, gluconeogenesis, and fatty acid oxidation. So basically, it's trying to build up your stores of fatty acids, glucose, and amino acids and prevent the breakdown. Quick and dirty, insulin will decrease your blood glucose concentration. It does this by encouraging glucose to be taken into cells, encourages storage of this as glycogen, and decreases gluconeogenesis. Factors that promote insulin secretion are a high blood glucose level, high amino acid, and high fatty acids, which all make sense. And also as part of the counter-regulatory system, if you have high glucagon levels or a growth hormone, that will also encourage insulin secretion. Insulin's responsible for decreasing our blood fatty acids and keto acids. It stimulates fat disposition and inhibits lipolysis. So you're going to store your adipose tissues at this time as well. Factors that decrease your insulin secretion are a low blood glucose, somatostatins, and catecholamines. So we have counter-regulatory hormones so that we're not constantly always storing glucose. These tend to be glucagon, epinephrine, cortisol, and growth hormone. They help to promote glycogen metabolism, lipolysis of stored triglycerides, mobilization of stored fatty acids, fatty acid oxidation, ketone production, resistance to insulin action, and gluconeogenesis. They inhibit glycogen synthesis, glucose utilization by muscle, conversion of fatty acid to glycerol and triglycerides. So again, it's doing the opposite. At this point, you're low on energy stores, so you're having to break down what you've stored previously, and you are inhibiting developing stores. So quick and dirty, simple version of it is that it increases your blood glucose concentration by increasing glycogenolysis and gluconeogenesis. Factors that help increase your glucagon secretion are low blood sugar, low amino acids, and catecholamines. It will also help increase your blood fatty acids and keto acids by increasing lipolysis and keto acid development in the form of beta hydroxybutyrate and acetoacetate. Factors that decrease your glucagon secretion are high blood glucose, insulin, somatostatin, and fatty acids and keto acids. So what happens in DKA? We have an insulin deficiency. So even despite having high glucose levels, we're still stimulating lipolysis. That leads to hepatic ketogenesis, where we're making ketones. This can lead to some vomiting, which further creates a base loss and ketoacidosis. At the same time, you're not able to use your glucose, so your body thinks that you're starving and will further increase your stress hormones, including glucagon, catecholamine, growth hormone, and cortisol. This also will stimulate some pro-inflammatory cytokines, which also get that fire going in even faster, encouraging further proteolysis and hepatic gluconeogenesis. This all leads to hyperglycemia. So you're unable to tell your body that you're hypoglycemic, and then you're encouraging yourself to continue to make more and more glucose. The ketones and excess glucose will combine to make a high osmolar level, so high osmolarity in your body, which makes sense. If we remember that formula for your serum osms, it's 2 times your sodium plus your BUN plus your glucose. And so those are going to lead to a high osmotic load, which your kidneys then try to help by making you pee more, which leads to dehydration. You also become further dehydrated with hyperventilation as your body's trying to correct your acidosis levels. This dehydration will lead to tissue hypoperfusion and eventually lactic acidosis, which creates further acid. So I was always kind of taught to remember DKA as starving as in the midst of plenty. So here you have all these stores all around you, and yet your body continues to think that you have no glucose available, and you're constantly making the situation worse by having those high glucose levels, leading to further dehydration. And I thought this meme was kind of appropriate for exactly what's happening in DKA. So how do these kids present? Dr. Gamble always likes to say, here comes all the polys. So you end up with polyuria. Again, you have a high glucose load, which your kidneys are trying to fix by dumping excess glucose stores into your urine. You'll end up getting thirsty because you'll have an intact ADH mechanism. So you'll have polydipsia, want to drink a lot. And again, you're starving in the midst of plenty. So these kids will often demonstrate polyphagia and be very hungry, but they'll have weight loss likely from the dehydration with some component of being unable to store any lipolysis and, any fat and constantly breaking it down. You can also have some abdominal pain, nausea, and vomiting. Again, kind of reviewing further symptoms as you get worse into DKA, you'll become tachycardic with low perfusion from your dehydration. Often these kids will have dry mucous membranes. They'll present with Kussmaul respirations as they're trying to compensate for the metabolic acidosis with the respiratory alkalosis. So they're trying to blow off all that excess CO2. You'll often notice that they'll have the fruity odor to their breath from their ketosis, so acetone scent. And these kids will also often be a little lethargic, decreased energy levels. They don't have that glucose available to be able to use as fats, and then altered mental status. Your brain can operate only with ketones or glucose. And so you're often going to be confused. And then also the decreased perfusion of your brain can lead to further altered mental status. So clinical findings, again, we'll see a lot of dehydrations. We reviewed that process and the pathophysiology. It's primarily from osmotic diuresis, from the hyperglycemia and hyperketonemia. Your nausea and vomiting will also exacerbate this fluid loss. As you become further hypovolemic, you get worsening renal function, which decreases your ability to get rid of this glucose and ketone excretion, and you have worsening hyperosmolarity. Usually these kids will present about 5 to 7% dehydrated. And we tend to overestimate their dehydration. That doesn't have a whole lot of impact upon their clinical recovery, but it's just kind of good to know that we tend to overestimate their dehydration levels. Full shock and hemodynamic compromise is really rare in pediatrics from DKA, but it's important to assess for in your initial assessment. On the left, I have included the severity of pediatric dehydration scores, so we can kind of get a sense of how dehydrated they are. Again, it's important to look at their heart rate, their capillary refill, what their mucous membranes look like, how sunken their eyes are. And this helps you kind of determine what your percent of dehydration is, which is really important for your calculations in the future. Initial lab work criteria that you want to look at. First, it's important to start with your ABCs, so airway, breathing, and circulation, and vital signs. You'll want to get an accurate weight on these patients. Ideally, it's best if you know their prior weight, but very rarely do we have that. So their current weight, and then we'll talk about how to figure out what their prior weight was. You want to assess their severity of their dehydration, again, using that score that we just talked about. How altered these patients are, what is their level of consciousness, and then again, lab work to confirm our diagnosis. The labs that we want to send for are the essentials that we absolutely need are electrolytes. We also need an ABG and VBG. CBCD is often important. The degree of hemoconcentration can help determine their severity. Also, looking for the possibility of infection. These patients will typically present with an elevated white blood cell count from their stress, but they can also have co-concurrent infections. You'll also ideally want a urinalysis if possible to confirm the presence of ketones. Other things to consider include your hemoglobin A1C, a beta hydroxybutyric acid. Again, you want to make sure that they are actually in DKA, not acidotic from something else like septic shock. Any other thing that might be on your differential, so you can consider things like chest x-rays, looking for infection, etc. And finally, your new onset labs, if they are new onset. You don't want to include your thyroid in this yet because it can be a little off when your body's so stressed. So we have our lab panel back, and just reviewing especially the electrolytes. First of all, your sodium. So you do have some sodium loss due to elimination from ketones and diuresis. So you'll have a little bit hyponatremia, but your sodium is going to be more proportionally lower on your labs than it is actually in your body. And this is secondary to dilutional hyponatremia. And that occurs because your glucose is so high that it's pulling excess fluid into your bloodstream. So your sodium looks lower than it actually is. Your total body sodium, therefore, is decreased by a lesser extent than what's suggested by your labs. If your sodium is initially high or normal, then you're going to worry that this patient might be more severely dehydrated than another patient who presents with lower sodium. As you're fixing your blood glucose as well as giving patients insulin, your sodium should rise. So it's important to kind of follow your sodium levels to make sure that's happening. When they first present, you can use your corrected sodium level. So for every 100 milligram per deciliter rise in our blood glucose above 100, you should have your sodium, your level of sodium needs to be corrected by 1.6 millimoles per liter, which kind of makes sense. As you have that increased glucose, you're going to have increased water. And so this helps to make the correction for the pseudohyponatremia. All right, next is potassium. So very important to remember that your total potassium stores are depleted. You have a major loss from your intracellular pool, which again, we talked about how insulin will help store it in the body. So it makes sense that you would lose it in DKA. DKA will also cause shift of potassium to the extracellular space. This occurs for a couple reasons. One's the absence of insulin. Another is the metabolic acidosis. So your hydrogen ions from the acidosis can become a buffer, or are buffered by the cells being swapped intracellularly, while potassium becomes more extracellular. You're also having a hyperosmolar state, which can increase your potassium initially. Osmotic diuresis and emesis promote potassium loss. So again, that goes back to us being total body depleted in our potassium. Your initial presentation may have normal or high potassium, even though your whole body's stores are low. This is again because of that fact that potassium is usually an intracellular ion, and we're looking at the extracellular component. So as we're giving our insulin, we're going to be correcting our acidosis, and insulin serves as an independent stimulus for potassium to go back into our cells. So it's important to remember as we start to pick our fluids, you're likely going to want to put some K in there, even if that potassium is high normal. You'll want to make sure that they're peeing first and that they're not in complete renal failure, because otherwise they can't get rid of that potassium. But will want to add some potassium to their fluids. What we might see because of this low potassium on our EKG as we're treating, or even at presentation in some patients, initially with lower Ks, you can have a lowered T wave. Eventually, it can lead to the development of this U wave, which you can see on this EKG. As our potassium levels become even lower, you'll see some ST depression and eventually prolonged PR interval with a prolonged, with a prominent P wave. And again, we still have the ST depression and the U wave. Hyperkalemia, also scary and something that you want to avoid. This can lead to a tall T wave initially. You'll then develop some ST depression. You get a prolonged QRS and fusion of the T, which is when things start looking a little ugly. You eventually will lose your P wave due to atrial arrest from the hyperkalemia. And finally, you can end up going into, I'm losing my train of thought, VFib or VTAC from hyper-K. Moving further along our electrolytes panel, our chloride. Typically, you'll show some hyperchloremia due to NaCl infusions. You also have chloride tends to follow your sodium, so it might be a little bit lower. This, especially as you're treating, your chloride is going to go up, which can contribute to your metabolic acidosis. As you have some vomiting at presentation, your chloride might be a little lower as well from that. So your chloride tends to start around normal and then might go up during your treatment. Bicarb, again, hopefully this one's slightly obvious. Without the insulin there, your body is starting to cause a bunch of lipolysis, leading to development of keto acids. You also have that dehydration and shock component leading to increased lactic acid. Your bicarb helps to buffer these ketones and keto acids, leading to lower bicarb levels. This also will lead to an elevated anion gap, and I included that formula on there, which is sodium minus your bicarb plus your chloride. And so as you use up more of your bicarb component, this gap will become bigger. Normal, your gap is 10 to 14, and so this will be much higher in patients with DKA. Excuse me, BUN, this tends to be elevated a lot due to the dehydration. Higher BUN levels indicate worsening prognosis for a patient. There's also some element of increase of the BUN just from the proteolysis from the glucagon. So as your body's breaking down amino acids, that's also going to stimulate some BUN production. Creatinine can be a little elevated from your dehydration, but often you'll see that it's elevated out of proportion to your BUN. This is because ketones can act directly with the lab when you're measuring your creatinine. So your creatinine tends to be a little falsely elevated just from the presence of ketones there. So you can't rely solely on your creatinine to diagnose acute kidney injury, or renal failure. Glucose, hopefully this one's self-explanatory that it's going to be really high because that's the whole thing we're treating here. Calcium. Your total calcium stores may decrease, especially if you're aggressively replacing your your phosphate. This tends to be rare. Your ionized calcium, when you first present, will often be elevated secondary to the acidosis. And that's because calcium usually is attached to albumin in your blood. But as you become increasingly acidotic, your body's going to want to buffer those H ions by attaching those to your albumin, and it will spit off a little bit of extra calcium. So you might have initially high elevated ionized calcium levels at presentation. As we correct our acidosis, this should get better. All right, couple more electrolytes. Phosphorus. Phosphate is often decreased, again, secondary to the osmotic diuresis. You're also not taking in as much. And so that's going to lead to overall lower levels in the body. As you begin treating with insulin, this is going to decrease even further. Why does this even matter? Who cares if your phosphate's low? Well, low phosphorus levels lead to decreased 2,3-DPG, which inhibits blood cells being able to dump off oxygen appropriately to our tissues. Phosphate's also really important for ATP production. So this is what's going to give us energy. So you'll see these patients have generalized weakness, can also eventually lead to seizures. So really important to keep your phosphorus stores intact. And you definitely want to replace if your phosphate level gets below 1. Ideally, we'll do this by placing K-phos in our fluids, which kind of serves 2 purposes. It helps with our phosphorus component, and it also prevents us from using KCl and causing too much hyperchloremia, preventing us from being able to closing our anion gap. Magnesium, again, it can be deficient in these patients. This is again secondary to that osmotic diuresis and decreased intake. With patients who are hypomagnesiemic, we'll see some rhythm disturbances. They can have some tetany and decreased level of consciousness, some weakness as well. Lastly, our PCO2. So again, as your body's trying to compensate for that metabolic acidosis, you start to breathe really fast. You can have some Kuzma or respiration and some hypercapnia. This leads to lower PCO2s on gases. These can be as low as 5 to 10. You don't need to do a lot for these patients. I've had transport nurses just insist that they are working so hard to breathe that they need more support. Typically, these patients are going to be better at hyperventilating themselves than we are. So just kind of expect that these patients are going to be breathing fast and have really low CO2s as they present. I'm not going to go through all of this graph, but it kind of goes through everything we just talked about. And I really liked it because it combines the pathophysiology with your symptoms and those lab values. And I thought it did so really well. And the colors made it really easy to look at. So this one's good for you guys to kind of look back on your own and kind of have a good overview of exactly what's happening in DKA. All right, so now what are we going to do with our patient who comes to us that we've diagnosed with DKA? Our treatment goals are to expand the intravascular volume just enough initially to restore our circulating volume, kind of improve our GFR so we can better clear our ketones and glucose, and we want to avoid cerebral edema. We want to be able to correct our deficits in fluids and electrolytes and start some insulin therapy in order to stop that catabolic process, the breakdown of everything, and resolve our acidosis. And during this time, we'll have to closely monitor these patients. I do not like DKA because you have to go low and slow with this. You can't just automatically correct them because if you go too fast, you can increase your risk for cerebral edema. So with our initial fluid resuscitation, again, our goal is mainly just to restore that effective circulating volume. You want to improve their perfusion. So those with really weak pulses might need a little bit more perfusion, especially if they're hypotension, a little bit more fluid. But generally, this can be done with just a 10 to 20 ml per kilo bolus. For this bolus, you'll want to use isotonic solutions. This can be in the form of normal saline or LR. You can repeat if you're still seeing some symptoms of shock. Your initial bolus will often decrease, your blood glucose, not your GB, by 200 to 400 milligrams per deciliter. So not uncommon to see some decrease in blood glucose with just simple fluid resuscitation. Again, you're not trying to correct their fluid deficit immediately. You're just trying to get enough so that you're able to restore good perfusion to your tissues. After we start that initial fluid bolus, then you'll start your ongoing fluid replacement. Again, our patients are typically presenting about 5 to 7% dehydrated. We often estimate 10%. This doesn't tend to have any effect on them clinically. But remember that if they're hypotensive, weak pulses, oliguria, then they're likely more dehydrated, tends to be rare, but more than 10% and might need more fluids. There's no reason to replace their urinary losses, but you do still want to monitor close INOs. And you're going to subtract all of those normal saline or LR boluses that they got at the beginning. So that can differ depending on which ER managed and how aggressively they resuscitated or what the patient needed. You want to solely correct this, again, to avoid the cerebral edema by doing this about over 48 hours. Some places will use 36. The typical upper limit of fluids that you're going to give today is 4 liters per meter squared per day. Again, slow and slow, and don't forget that you have to add in your maintenance fluids. So how do we calculate how much fluid these patients need? I included Hubbard here because I can just hear him saying, If only someone would have put this on a card and laminated it for you. So this is on our cards. It's really nicely laid out. But you're going to want to first estimate how much fluid deficit these patients are in. This can be done based on weight loss or their percent dehydration. You want to account for any boluses that they've already gotten and divide these fluids over 36 to 48 hours, and finally add the replacement fluids to the maintenance IV fluids. So let's practice one. We have a 20 kg kid who comes in, he's about 7% dehydrated, and he's gotten a 400 ml normal saline bolus, so 20 cc's per kg in our emergency department. So if we look at our fluid deficit, again, they're about 70 mLs per kilo. We got that from our 7% dehydrated times our 20 kilo equals 1,400 mLs for our fluid deficit that we're getting for this patient. They've already gotten a bolus of 400 ml, so we can subtract that from our total of 1,400 that they need, and we get about another 1,000 that they need over 48 hours. If we divide by 48, the rate of this is a little over 20 mLs per kilo, but it's really nice to keep it in nice even numbers, so it's much easier for you to be able to do the triple bag method, which we'll discuss eventually. Finally, we almost forgot, we have to add in our maintenance fluids. So maintenance for this patient would be 60 mLs per hour, plus that additional 20 equals 80 mLs an hour that you're going to run this patient at for the next 48 hours. All right, so moving on to insulin. It's very important that in pediatrics, we do not bolus insulin. This will increase your risk of cerebral edema. So do not bolus your insulin trying to get that glucose to come down fast. We want a low, steady rate of decline. This can be best achieved with placing the patient on a continuous insulin, or excuse me, a continuous infusion drip of insulin. Usually we'll start this at 0.1 units per kg an hour. Sometimes we'll start at 0.05. That tends to depend on user preference and sometimes depending on how sick the kid is and how worried you are about them dropping their blood sugar too quickly. The insulin is so important in this process because this is what's undoing the whole dumpster fire you started when you were in DKA and had low insulin. So this stops that keto acid production. It lets your body know that there's sugar available and starts to help build up your stores again. It stops that catabolic nightmare that's going on right now. So encourages your metabolism of your keto acids and helps to actually generate bicarb from them, which is going to improve your acidosis. It's ideal to start this insulin about 1 to 2 hours after you've started that IV fluids and started to generate some reperfusion for these patients. And you don't want to stop your insulin. You want to leave that on until your ketoacidosis is completely resolved. So optimally, as we're giving our insulin, we don't want our blood glucose to drop by more than 100 milligrams per deciliter per hour. So we'll have to follow our blood sugar closely and we will adjust things in order to make sure that happens. If we go too fast with our correction, we can again increase our risk for cerebral edema. So we'll have to give sugar to help combat that. If your blood glucose drops too quickly, you can then add some dextrose to your fluids first, and then second, you might end up having to decrease your insulin drip rate. But again, you don't want to stop that insulin because that insulin is important to stop the whole process of DKA. It stops that catabolism. So that's really the problem in DKA, not so much the hyperglycemia, though that is playing a large role. If it drops too slow, you might need to increase your insulin drip a little bit. This tends not to need to be done, but you might have to, but it's important too, if you're not seeing any decrease in your blood glucose, to say, are they getting this medicine? So we've had sometimes where the nurse thought it was hung and going in and it wasn't, or your vein might be bad, or it might be an improper mixture of your insulin. So you might need to get a whole new bag. So make sure that you're not causing their blood glucose not to drop as fast either. So as we lower our blood glucose, we'll might need to add some sugar. Typically once your blood glucose ends up in the 250 to 300 range, you can switch to D5. And once it's less than 200, you'll be on D10. And your blood glucose target is about 150 until your DKA is resolved. So rather than having to keep ordering a ton of bags of fluids from the pharmacy. We tend to use the triple bag method, which initially sounds really overwhelming to patients, to students and sometimes residents, but as you get to use it more, it kind of makes sense. So your triple bag includes 1 bag of D none, so no dextrose. So this usually is just normal saline. Sometimes it might be half normal saline, depending on your patient's labs and what they need. D10, so again, a dextrose component bag. This will, I usually like to make my D10 component have half normal saline, so that I don't have that hyperchloremic problem. And then your third bag is your insulin. Again, our insulin drip tends to run just at 0.1 units per kg per hour, so you can kind of forget that that one's there for a little bit. So when our patient comes in, they have hyperglycemia, let's say their glucose is 400, you're going to want them to get no dextrose. So all of my component will be in that D none bag of fluid. So that will run at 80 mLs an hour for our patient, while our D10 component will run at 0 mLs per hour. As our glucose improves, and we're in that 250 range, so say 275, we want a D5 amount of sugar, so we can make that really easy by just alternating our rates. So now we run our D0 component, D none component at 40 mLs per hour, our D10 component at 40 mLs per hour for a total of 80 still, but we're overall giving a little bit more sugar. Finally, as they get down less than 200, we'll need all the D10, so we can switch to 80 mLs per hour and that D10 component and have our D none currently off. So getting 80 mLs per hour of this. For some patients, you might have to even fine tune a little bit further, doing like 75% of one or the other, depending on what their sugars do. But again, this just makes it so that you don't have to order a ton of fluid bags from the pharmacy. All right, don't forget our electrolytes when we're making our fluids. So again, we talked a ton about how our total potassium and phosphate are all depleted. So you want to make sure that you're going to add some potassium into the cells, or excuse me, into the fluids for these patients. Insulin is going to drive potassium in your cell, and that's going to help rebuild these stores, but you need to be able to supplement them. Generally, for our patients here, we'll use 15 MEQs of K-phos and 15 MEQs of K-acetate. You don't want to use a lot of K-acetate in these patients, again, because that can increase their, cerebral edema risk. So as we're treating these patients, it's important to constantly monitor them. You're going to get Q1 hour blood glucose levels. You don't want that glucose to drop. We'll discuss that further when we talk about cerebral edema. You'll want electrolytes every 2 to 4 hours, depending on how sick the patient is. You need strict ins and outs. They'll need to be on cardiac monitoring because of the problems that they can have with their electrolytes and those effects upon the heart, and also frequent neuro checks, again, because of the risk with DKA that occurs with risk of cerebral edema that occurs with treatment. So when I was in residency, we always called this the kiss of death, because you were going to be up all night getting called every hour with a sugar. But I feel differently about it now as an attending. Sodium bicarb, you almost never ever want to give this due to its increased risk of cerebral edema. So if I correct that serum pH too quickly, it will lead to a rapid rise in my PCO2, and that can kind of be shown in that picture on the right, that your bicarb breaks down into CO2. This can eventually cross the blood-brain barrier and lead to cerebral acidosis, which is not a good thing. So the only times that you're ever going to really use this is if your metabolic acidosis is so severe that it's leading to cardiorespiratory compromise and life-threatening hyperkalemia. So if I have really bad cardiac output, then I might need to give some bicarb, or if my K is so high, then I might need to give sodium bicarb. Otherwise, big no-no, don't give it. Again, low and slow correction in DKA. So what complications might we see? Again, the big one is cerebral edema. This tends to occur in about 1% of DKA cases officially, but all cases typically will have some degree of this. It might be subclinical. A lot of times we won't see it on imaging, but it's always going to be there. For those that does become clinically overt, there's about a 20% mortality rate. So definitely something that we want to avoid, high mortality rate. with cerebral edema. The classic presentation that you'll have is progressive CNS decline as you start treatment, and it usually starts about 4 to 12 hours after starting your therapy. However, some cerebral edema will occur even before you start your treatment, and that is about 5 to 30% of patients. So why does this happen? So one of the huge theories about cerebral edema has to do with the osmolarity and fluid shifts. So if you think about having your cells and then my mouse isn't working, I apologize. Your cells and then your high osmolarity from your increased glucose levels, your increased BUN fluid will shift out of your cell into the extracellular component in order to make your osmolarity look similar between the two areas. In order to not lose all of your fluid in your brain cells, your brain gets really smart and starts to make idiogenic osms. So that's what these red things are here. And that helps to retain some fluid inside your brain cells. So if I too quickly come and wipe out all of this glucose that's in my bloodstream, then I can have fluid rapidly rush into my brain, leading to edema, causing cerebellar edema. But this doesn't fully explain cerebral edema. Again, we have some patients that start to have it even before they present. So several people have done a lot of studies looking further into this. What they found is at presentation, you'll have some narrowed cerebral ventricles in 50% of DKA cases with evidence of hypoxic and ischemic stroke pattern, showing that vasogenic edema, so from changes in your blood-brain barrier and your blood vessels and perfusion of your brain, might be the bigger component that leads to cerebral edema, so that the edema might primarily be vasogenic rather than osmotic in nature. This severity of the vasogenic edema tends to correlate with your BUN levels. So again, higher BUN patients are sicker. In the MUIR study, he found that 9 out of 23 patients with DKA-related cerebral edema had no CT abnormalities at the time of decline, but once they were repeated later, they showed evidence of edema, infarct, and hemorrhage. So a lot of this is going to be clinical with some element of looking at your imaging. And again, while we think about the importance of osmotic shifts, a big player in our cerebral edema is actually vasogenic. So why does that happen? Again, you're really acidotic. You're trying to buffer this. And so you're breathing out a lot of CO2. As you breathe out CO2, your brain cells, your blood vessels in your brain will vasoconstrict, and that decreases our cerebral blood flow. This is further compounded by our dehydration and our decreased perfusion that we might already be seeing. So as these patients present, they'll have a decreased cerebral blood flow component. This leads to cerebral injury and cytotoxic edema. As we rehydrate them and reperfuse, we'll start to get some reperfusion injury, hyperemia, and vasogenic edema. Again, this is the theory that this is what's actually playing a bigger role in our cerebral edema. And so going low and slow can help here as well. So what does this all mean? Clinically, we see subtle cerebral edema with more frequency than we actually thought. Severe clinically apparently cerebral edema is actually like the most extreme presentations of those, which is actually a common pathophysiologic phenomenon that we're seeing in DKA. So it kind of occurs in every patient, but only a few are going to present clinically severe enough with it. Cerebral edema is not solely caused by DKA treatment, but some aspects of our treatment can make it worse. And so we don't want to cause worsening with what we're doing. Cerebral edema might actually be the consequence of a primary neurologic injury with that vasogenic edema rather than the cause of neurologic damage. So which patients are more likely to get cerebral edema? Again, younger onset, likely because they're more severe at presentation, but those less than 5. If we vigorously rehydrate, we get more reperfusion injury, and we also cause more osmotic edema. So those are at higher risk. New onset patients often tend to be at more risk, again, likely because they present sicker because they're less familiar with the signs of presentation. Giving bicarb, so bicarb again, no. Greater degree of hypocapnia after adjusting for the degree of acidosis. So again, if these patients are hyperventilating so fast, they're decreasing their blood flow to certain regions of the brain, leading to that vasogenic edema. High BUN, prolonged duration of symptoms, and administration of insulin in that first hour. So you ideally want to save your insulin until an hour after treatment with the fluids. How do we identify cerebral edema? So again, you have cerebral edema, so you'll have that starting of Cushing's triad where you might have some inappropriate slowing of heart rate, hypertension, severe headaches, vomiting, irritability, and lethargy. In the MUIR study, he came up with these criteria, which are 92% sensitive for predicting. So you might treat a couple extra patients with it, but better to not miss. So for always present, you have to have at least one of these: abnormal motor vertebral response, decorticate or decerebrate posturing. You might have a cranial nerve palsy. This tends to be cranial nerve 2, 4, or 6, or an abnormal respiratory pattern. For my major criteria, you can have 1 to 2 of these. If you have 1 of these, then you need 2 minor criteria. If you have, or you can just have 2 of these. So this includes loss of consciousness, decreased heart rate by more than 20 beats per minute, and incontinence that's inappropriate for their age. The minor criteria, again, if you have 2 major, you only need 1 minor, or if you have 1 major, you need 2 minor. And these are emesis, headache, lethargy, a diastolic blood pressure greater than 90, or age less than 5. So how do we treat it once we recognize it? If you're using half normal saline, you want to switch, or LR, you want to switch to normal saline. That can just help better treat cerebral edema. We'll talk about that in a little bit, but it improves that osmotic fluid shifts. You'll want to elevate your head of the bed, and then we can use 2 different treatment methods. The first is mannitol, so you can give 0.5 to 1 grams per kilo IV as a bolus, or you can use 3%, 5 to 10 mLs per kilo IV as a bolus. You can also start them on a 3% drip. You'll ideally want to get a head CT to make sure that you're not missing something else that's going on. Again, we'll talk about later, these patients are at increased risk for venous thrombosis, and as well as having strokes or bleeds. So really important to not make sure that you're not missing something by assuming that it's cerebral edema. If you have to intubate, it's important not to hyperventilate. Again, that hyperventilation, that low CO2 is going to worsen your blood flow to your brain. So if they're doing it on their own, good for them. There's some benefits to it, but don't do it mechanically to them with a ventilator. So if we decide to give mannitol, how does it work? The most common answer I get to this when I ask on rounds is the osmotic effect. So it is true that it will help your osmotic cerebral edema by causing fluid shifts, so it increases the osmolarity in my bloodstream. But there's actually a couple effects that tend to work faster first. The first is it improves your rheology in your brain, in your blood, by lowering your hematocrit and blood viscosity. So blood's going to travel a little bit more smoothly through your brain, and that's going to help some with your cerebral edema and by improving your blood flow. You also get improved blood flow with improved red cell deformability. So they're better shapes. They're going to travel a little more smoothly through your vessels. It can help improve the vasoconstriction in areas of your brain that have intact autoregulation. And there are some theories that say that it's also going to help with your autoregulation in your brain. So it's going to help, again, just improve overall perfusion. And that's going to help with your cerebral and vasogenic edema. You also have to be careful when you're giving mannitol. You can't give an extended use of it or use a lot of it. You'll start to see some rebound edema, and it can also lead to renal failure. And so that's why 3% kind of tends to be our main treatment long-term in these patients. So should you intubate or not? You don't need to intubate these patients just because they have cerebral edema. As long as they're breathing, they can do a better job breathing for themselves than you can for them. Also, as you're starting to intubate and switching from negative to positive pressure ventilation, you're going to cause a lot more problems with their dehydration status. So intubation on diabetics is a very risky thing and should only be done when there's severe respiratory compromise. And again, just to reiterate that you don't want to hyperventilate these patients. If you hyperventilate and lead to low CO2s, you're going to decrease your brain perfusion, and that has a worsened outcome. That's been shown in a lot of studies. So main point with cerebral edema is that an ounce of prevention is worth a pound of cure, and that's why you got to go low and slow. You don't want that reperfusion injury, and you don't want those rapid osmotic shifts. So the best way to treat cerebral edema is to not cause it. Another big complication process that we can see in DKA is coagulopathic. So if you think here on the left, we have Virchow's triad with blood stasis, vessel wall injury, and hypercoagulability. And DKA patients tend to have a big risk for all of these things. They're very dehydrated, so they are increased risk to coagulate. And then they have slower blood flow because of their dehydration status, and they'll also have some injury to their vessel walls. So they are at high risk to clot. There's been a few studies that looked at this. Gutierrez found that in 4 of 8 children with DKA that got a central line, they developed a DVT versus 0 of 16 of his controls, which were well matched with the same degree of dehydration. So these patients have increased risk of clotting. The younger kids are at higher risk. Again, this makes sense because they have smaller vessels, and you're just putting something foreign in there and you're blocking blood flow, causing further stasis. So more risk of clotting. Ideally, you don't want to put a central line catheter in anyone with DKA unless you absolutely have to. These patients also at risk for developing cerebral venous thrombosis. So think about that if they have a seizure, or again, when they're altered and you're getting that CT, you might need to also look at their veins with some contrast. They can also develop stroke from that reperfusion and vessel injury. Other complications that we can see, you can get some element of rhabdomyolysis. This tends to be more common in the hyperosmolar hyperglycemic syndrome, HHS, but we can see sometimes in DKA. It's usually subclinical, so all patients probably have a little bit component of it, but very few will be affected. Unclear mechanism of exactly why it happens, but a lot of cellular breakdown will lead to increased potassium and myoglobinuria, and then you can have worsening renal failure. You can also see new aminocytoma in some of our DKA patients. This makes sense as they're vomiting. They can get some high pressures in their alveoli and pop a few. Usually this does not cause any problems for them, but something that you'll want to watch out for. A couple patients will develop pancreatitis. Generally at presentation, they'll all have an elevated lipase level. So unless they have severe belly pain, it's not that helpful to check, but if it persists, it's worth checking a lipase level. You can additionally get some intestinal necrosis and GI bleed, high stress state, high elevated levels of cortisol. They're not eating and sometimes vomiting. So very important for stress ulcer prophylaxis in these patients. And lastly, you can see rhinocerebral mucormycosis, which is a bad infectious process with high morbidity and mortality rates. Overall, though, DKA has a low mortality rate of 0.25 to 0.3%. Cerebral edema accounts for about 57 to 87% of this, which is why we're so careful to try not to cause it. Other causes of mortality in DKA include sepsis, electrolyte abnormalities, arrhythmias, and pulmonary edema. And again, I included Gamble because this is his favorite, because in general, DKA just gets better, which again is why I no longer look at it as the kiss of death, because it's finally a patient I can usually make better pretty quickly relatively to the rest of my unit. So I think that's close to time. I thought this picture was accurate because I think she needs a break and we probably do too. So any questions at all? Yay. All right, I guess we get an extra bonus 3 minutes then. Thank y'all.